love taking care of kids. I see a lot of the happy wellness kids, and they come running. I had one little kiddo. I've just seen him since almost the day he was born. And yesterday he comes running to see. I went around the corner of my office. He came running up, Dr. Ruben! And he runs up, big hug, and he gives me this monkey hug, and he's holding on to my legs and his legs, and I'm like walking around with him like this, and we're just doing this beautiful monkey hug, right? And I love this little boy, and that's a beautiful thing. But that's not all the kids that we see, right? We see the really, really challenged ones. We see the kids on the spectrum who do this, who literally do this. This is not a one-time thing. This is a thing. There are kids who do self-harm on a regular basis, like this. And now, how come it is that he can do this and walk away and appear to not be in pain? Well, he's used to it, maybe. That's part of it. But there's something. Think neurologically. What's happening in him with him?
Adrenaline.
Well, adrenaline, maybe fight or flight. Yeah. He doesn't feel it. He doesn't feel it. You and I would feel this. This doesn't feel like anything to him. Imagine that being that disconnected, that slamming your fist full force into your own head, and you don't even notice it. Kids on the spectrum, especially those more severe, have significant brain changes than kids who are neurotypical. It's just the way it is. And I'm not talking about esoterics, and I'm not just talking about whether they're a little different in how they act or whatever. I'm not talking about behavior. I'm talking about if you do the research, and you look at the MRIs, and you look at the CAT scans, and you look at the QEEGs, and you read all the research papers, like I've had the great fortune of reading with Dr. Melillo and all the kind of stuff that I've done with functional neurology, you're going to realize that these kids literally have different connections. There are different connections in their brain. The cross-hemisphere connections, there's a lot less of them. The intra-hemisphere connections, there's a lot more of them than in a neurotypical child. It's the way it is. You can read the papers. I can show them to you if you need to see them. That's just the way it is. What that does is it changes interoception. This same kid, do you think he knows when he has to go pee? No. Do you think he knows when he's hungry? No. When he's hungry, what do you think he does? Probably this, or he acts out, right, when he's really hungry, right? So someone has to constantly keep on top of making sure that, hey, are you going to the bathroom? Are you pooping? Are you peeing? Are you hungry? Are you thirsty? Because this child does not have the same brain and nerve system as these kiddos do. And what that means is you have to adjust them differently. I want you to get that into your heads. We talked about it in lab, and we're going to talk about it ad infinitum in this class. These kids need a different approach. You cannot approach these kids the same way you approach this one. Their brains are different, their nerve systems are different. You need to approach it differently because this kid isn't going to let you in the way you would a neurotypical kid. You can tell this cutie over here, you can say, hey buddy, will you lie down? We're going to do adjustment. Okay, cool, yeah. You can't do that with a kid on the spectrum who's level 3 spectrum. No way. It's not happening. So you need all the tools, which is what we talked about in lab. You need all the tools. We need tonal techniques. We need sustained contact techniques. We need instrument techniques. And we need full spine techniques. We need all of them. And you need to know when to use which technique on what kid. And that's what I want to teach you this quarter. Because this is what I've been doing for the last 37, going on 38 years. Is I've been dealing with these kids. And I love working with kids like this that are happy and bubbly, and the kid gives me a bear hug, and that's so cool, right? But I really love working with kids like this and watching them change. So we had a kiddo come in last year, very similar to this, except he didn't just do it when he was angry, he did this all day long. So the new patient examined him, he's 16 years old, his new patient exam, he sat there and he punched himself. The entire new patient exam, as we were doing the history, the entire history, and when I first, and usually I have the interns do this, and then they come and get me, and the intern came in all flustered saying, I don't know how you could do this exam because this kid just hit himself the whole time. in his head. I said, it's okay. We're gonna build trust with him. That's going to be my goal, is to build trust so that he doesn't have to do that anymore. So he can trust me and he can trust the environment, right? Because the reason you're really doing this is you're trying to, this, believe it or not, is a self-soothing thing. Some kids do this, right? Some kids will flap, and some kids will spin, and some kids will stim, like with their fingers like this, and some kids will verbally stim. It's called scripting. And let's say ABC, 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 ABC. And you have got to be doctor enough to be okay with all that. Perfect example. And then I'll go back to this other kid. Perfect example. So this kiddo came in a couple weeks ago, and this was around the holiday time, and I was dressed as the Grinch, and the other interns and staff were all dressed as different Who's, from Whoville. So I'm adjusting this one young girl. She's like 6 or 7 years old, and we have an outdoor, an open adjusting area like here, like 5 adjusting benches, and then we have 4 adjusting benches, and then I have some rooms in the back where we take some of the more severe kids. She's more like autism level 2, where she requires a good amount of support, but not significant support. And so we're adjusting her in the main adjusting area, and she's lying face down, and I'm adjusting her. And then she turns over so I could work on her cranium, which we'll talk about momentarily. And she said to me, "You're the Grinch." I said, yeah, I'm the Grinch. Right? And I'm looking at her legs, right, to do an Atlas check. And she said, "You're the Grinch." Yeah, I'm the Grinch. That's right. Yep. And I'm doing legs, and now I'm adjusting her Atlas like this. And she looks at me like this, and she said, "Why are you the Grinch?" And I said, well, because this is the holiday time, and the Grinch is, there's a movie and like that. And she said, but you're the Grinch. And everybody is watching me, right? The other patients, because we got patients, other patients are watching, the staff is watching, and I am, now what could you say if you were like, didn't want to talk about this? I told you already, right? I am the Grinch. Don't ask me again. Right? And I see this with parents all the time. Don't ask me again. Stop talking. I'm the Grinch. You know I'm the Grinch. This conversation is over. Right? I kept on saying, yeah, I'm the Grinch. She must have asked me 6 times. You're the Grinch? Yep, I am the Grinch. Right? And that is the different sort of doctoring you need to learn. Is you don't cut people off. You don't cut these kiddos off when they ask you the same question over and over and over again. You don't tell them to stop repeating the thing over and over and over. You don't tell them to stop doing this, or even stop hitting the head. Stop it again. There's no conversation in saying, I would like you to stop hitting your head, because they don't get that, right? They might understand the words. This one boy that I was working with who hits his head like this the whole exam, he understands, don't stop your head, but he's not going to stop because you asked him. What will make him stop? Well, we mean his knees, what was it?
Balance nervous system.
Yeah, when you balance his nerve system. So we started doing adjustments. Do you think he was lying face down with the adjustments? No. He was sitting up. And he was kind of doing this, and I would try to kind of avoid his own hitting his head. And I used sustained contact, which we're going to talk about momentarily, and we'd do cranial work, etc. And we do all these different things. And what do you think happens after 10 visits? We do a re-exam. Every 10 visits we do a re-exam. What's the first thing the mom says? He stopped hitting his head. Is that me? Is it me? Am I some miracle worker? No, because the brain works when you work it. But you got to know how to get there. You got to know how to get to the brain. You got to know what parts of the spine you need to work on to get to the parts of the brain that need to be worked on. Right? We talked about this in lab. The most important parts to work on, Dr. Webster, my teacher and hero, Dr. Larry Webster, the founder of the ICPA, used to say top and bottom. We got to get top and bottom. So, yes, did he have thoracic subluxations? For sure. Did he have lumbar subluxations? Absolutely. Did I touch them? No. Not in the beginning. Not in the beginning, because you don't have to adjust everything you find in the beginning. You adjust what needs to be adjusted. His nerve system is in fight or flight. This kid's nerve system is in fight or flight. I don't need to adjust sympathetics right now. He's already there. What we have to adjust as parents over there is to calm his little nerve system down. We calm the nerve system down, and now he stops hitting his head. And that's the power of what we can do. That's the power of what you guys are capable of. Because it wasn't a Drew Rubin thing. This is what any of you could do the same exact thing that I did with the same exact kind of kid. All it takes is knowing what to do and knowing what not to do also, right? Because that's just as much the art of chiropractic. The art of chiropractic isn't just learning how to adjust, it's what not to adjust and how to do. So you have to master the things to adjust, but you also have to master the things not to adjust. Yeah, I could adjust the thoracic. I know how to do that, but I'm not going to do it in the beginning. Later on, we'll get to it once his nerve system is balanced. But until that time, we're not going to touch it. And that's what makes the changes with these kind of kids. And that's what I want to show you guys this quarter. Because I am super into research. So this is one of the most important latest research papers that's come out recently. It is a huge mouthful of a title. And the title really does not do what's really going on with this justice. Right? This decomposition of phenotypic heterogeneity and autism reveals underlying genetic programs. I don't even know what that means. Like putting that together, that's like a couple of PhDs, like adding some highfalutin words. Here, I'm going to show you. This is a great Twitter. This person really came up with a great sort of subtitle for what this is. It's Decoding Autism, four distinct subtypes revealed by genetic blueprints. So here are the 4 types of autism according to this new research. Now, how many people know, remember my wife talked about the DSM, right, with you guys? My wife is Dr. Lisa Rubin, in case you haven't figured that out. We're married. 38 years this year, guys. She probably taught you the DSM, and if you learn the DSM in autism, what are the 3 levels of autism? You guys go over that?
I'm sure she did. I have to start.
You don't remember? All right, well, I'll tell you the 3 levels of autism, right? Autism level 1, this is according to the DSM. Autism, so it's not this stuff. It's autism level 1 according to DSM is like they need some support. So a lot of these kids are relatively verbal. Some of them are fully verbal. Some of them are going to school. We have a lot of patients like this who are, you couldn't even tell, unless someone told you they were on the spectrum, you had no idea. So some of them are very, very high functioning. And one of the biggest things that I do not like is this term functioning, because I think that that's a term that's kind of very loose, and I'm not a big fan of calling it functioning, but that's just what the DSM uses. So that's level 1 autism. Level 2 autism is they need more support. They're more challenged, they have less verbal abilities, they have more issues, etc., more impairments and stuff. So that's the level 2 kids. So these kids need more support. And then level 3 need significant support. They need a lot of support. These are usually the minimally speaking kiddos. There's the kiddo like who's just hitting his head over there. The kid's probably not speaking. And you could look at this and say, you could just look at that video and say, that kid's hitting his head, he's probably not talking. Right? That's how a lot of this stuff kind of ties in, together. I don't like that particular way of demarcation, although that's how the DSM does it. I don't like it, and the reason is because it's very limiting. Because there are some kids who have autism that you can hardly even tell have autism, and they're only getting the diagnosis to help them with services in school, which is totally fine, but they hardly even qualify because the autism level 1 is this big broad category, and autism level 2 is this big broad category, and level 3 is this big broad category. We have a kid, as an example, in my practice now who is autism level 3, but he's very high functioning, even though he's minimally speaking. But he can do a lot of things on his own. He actually uses a letterboard. We've taught him how to use a letterboard so he can point to things, and now he can spell like anything, and he's able to communicate. He's got a communication device that he's able to spell and point to things. He's a very high functioning kid. Even though he's in level 3, he doesn't really belong there. It's really not. See, so it kind of doesn't make sense. This, I think, is somewhat better. I think there's probably 8 or 10 different subtypes, honestly, instead of 4. But this is the latest thing. At least we're trending in the right direction. So we have the moderately challenged kiddos, which is 34% of the cohort, And these kids have core autism traits, but they are able to kind of function. That probably would be almost considered a lot of the autism level 1 in the DSM. Then we have the social behavioral kiddos, 37% of the kiddos. These have a lot of social and behavioral difficulties. So these kids have a lot of problems in their communication abilities, but when they were young, they did not have developmental delays. So when these kids were little, some kids on the spectrum have a lot of delays. These kids didn't have any delays when they were little. Then we have the mixed ASD with developmental disability thing. These kids are significantly affected. It's about 19%. So they have language impairment and developmental delays. So this is a smaller percentage of those kiddos, but this is what they're seeing. And then this is 10%, which is the broadly affected. These kids are significantly affected and having issues cognitively and developmentally and physically. So I think this is better, but then if I was to do this, I would probably have like 2 more subheadings in this to make it truly complete. Even though this study at least has like 5,000 kiddos, which is the biggest study to date so far, I think a lot of the studies that I see that are done out there are done by researchers who don't actually deal with the kids; they deal with data. I think they need to have some researchers out there who are actually dealing with these kids themselves to actually make the demarcations, because that's when you see these. The variation of someone with autism that you can hardly tell versus the kid who is hitting his own head and not speaking is dramatic. And you can't put that into 3 or 4 categories, right? To me, it's so many more categories. But chiropractically, the big question is, how do we adjust them? And to understand that we adjust them differently in the beginning, and then as we get to know them, we will change our adjustments based upon what is happening with them. As their nerve system improves, so will our adjustments. Our adjustments will change. We'll go from very gentle, tonal, sustained contact kind of adjustments to more instrument-based adjustments, and then more osseous-based adjustments if they so desire and you so desire. So you need to have these different tools that we're going to talk about this quarter, so you're able to figure all this kind of stuff out.